Ladies and gentlemen, today I would like to briefly discuss a very common but important issue in cataract practice: postoperative medication after an uncomplicated phaco emulsification with intraocular lens implantation. We all agree that modern phaco surgery is remarkably safe and minimally invasive. But surgery does not end when we remove the instruments from the eye. The post-operative period is equally important for achieving a quiet eye, rapid visual recovery, and an excellent final visual outcome. For that reason, I have set up 4 principles in this regard. Principle 1. Control of post-operative inflammation. Even after an uneventful phaco, there is disruption of the blood-aqueous barrier and release of inflammatory mediators. Therefore, a topical corticosteroid remains the mainstay of post-operative anti-inflammatory treatment. A commonly used regimen is prednisolone acetate 1% or dexamethasone. Initially, several times daily, followed by gradual tapering over approximately 3 to 4 weeks, depending on the degree of inflammation. The important principle is not simply the choice of steroid, but adequate initial suppression followed by an appropriate taper. And we should remember one important adverse effect of steroid is steroid-induced ocular hypertension. Therefore, patients at risk of pressure evaluation need appropriate IOP, intraocular pressure monitoring. Principle 2. Prevention of cystoid macular edema. The second major objective is prevention of pseudophakic cystoid macular edema. Here, topical non-steroidal anti-inflammatory drugs have an important role. They inhibit cyclooxygenase-mediated prostaglandin synthesis and complement the action of corticosteroids. The evidence supports the use of non-steroidal anti-inflammatory drug plus corticosteroid rather than either drug alone for routine cataract surgery. In the ESCRS PRAMED study, the combination strategy produced a lower incidence of clinically significant macular edema than either bromfenac or dexamethasone alone. Therefore, in my practice, particularly in my patients at increased risk of cystoid macular edema, such as diabetics, patients with previous CME, or retinal vascular diseases, or other macular pathology, I would be more inclined to use NSAID for several weeks along with steroid. Now, principle 3. Judicious use of post-operative antibiotics. This is where our practice is changing. Traditionally, we have routinely prescribed a topical 4th-generation fluoroquinolone for 1 week or longer after cataract surgery. However, if the surgery is truly uncomplicated, the wound is secure, proper povidone iodine antisepsis has been performed, and an appropriate intracameral antibiotic has been given, the necessity of routine post-operative topical antibiotics is increasingly questioned. The ESCRS recommendations strongly support intracameral antibiotic prophylaxis, for example, ceftazidime pentahydrate 1 mg in 0.1 milliliter to reduce postoperative endophthalmitis. Indeed, current European practice increasingly moves towards antibiotic stewardship and shorter or selective post-operative antibiotic use, particularly when intracameral prophylaxis has been used. Principle 4. Do not forget the ocular surface disease. Cataract surgery can temporarily worsen dry eye symptoms. Preservative-free lubricating drops are therefore useful, particularly in patients with pre-existing ocular surface disease. Finally, medication is only one part of postoperative care. We must tell the patient, don't rub the eye, use drop correctly, keep adequate interval between different drops, and most importantly, report any unexpected deterioration, like increasing pain, increasing redness, photophobia, sudden reduction of initial improvement of vision, new floaters or flashes. If this happens, they should immediately raise suspicion of complications such as endophthalmitis or cystoid macular edema or raised intraocular pressure or retinal pathology. So the modern approach is therefore steroid for inflammation, non-steroidal anti-inflammatory drugs for cystoid macular edema prevention. So the modern approach is therefore steroid for inflammation, non-steroidal anti-inflammatory drug for cystoid macular edema prevention, lubrication for ocular surface, and antibiotics according to the surgical protocol and risk profile, not simply by routine. Thank you for listening.